Yeah, right now we're going to go ahead to invite Dr. Ibikunle to take over the invisible mic, the virtual microphone. Dr. Nima, can you hear me?
Yes, I can. Hello.
Awesome. And Dr. Nima, you've been made co-host. If you want to share your screen, let me know if you're able to do so.
Okay, just give me a few minutes, please.
Okay. And while we wait for Dr. Nima, I think we lost Karima some time during our presentation. I would like to re-emphasize something about Dr. Nima, who is our presenter for today. She is very committed to what she does, and she is a member of the West African College of Surgeons. And because of the recognition of her exceptional skills and dedication to the high standards of healthcare, her proficiency extends beyond clinical excellence. She is very passionate. She's a passionate advocate for child protection. And I remember one time she was the host for one very big outreach that was talking about women and girls, especially. And she was promoting girls being protected from sexual abuse. So she's a full package, and I'm sure that she's going to use her expertise to deliver the topic today. Dr. Nima, are you ready? Let me know. Once you're ready, let me know. And if you want us to share the presentation slides as well, we can do that.
Okay, I think I would prefer that. Thank you.
Okay, we can do that for
Okay,
you for
so
sure.
yes, so I would go ahead while I await the sharing of the slide.
And we
Okay,
would
good evening.
appreciate if you could put on your video, your camera as well. Thank you.
Okay. Hello.
Hi, I believe my screen is visible now.
Yes, I can see your screen. Can you see me? Hello.
Yes, we
Yes,
can.
Can you see me?
Yes, we can. You can go ahead. And one more minute, everyone. If you know someone who needs to be at this webinar and is not here, kindly send them a message because they would be missing out a lot. Thank you all so much. Dr. Nima, you own the floor now.
Okay, so good evening, ladies and gentlemen. If there is any man with us, because this is majorly a girls' talk, but then any man that is with us is highly welcome. So we are going to be demystifying polycystic ovarian syndrome, as the topic says, navigating through the spectrum of polycystic ovarian syndrome. And you would see why we said it's a spectrum and why it's a navigation as we go through the discussion. Thank you so much for um, coming around. Without much ado, I'm going to be going ahead with the presentation. So the next slide, please. Yes, this will be my outline of discourse. I'll be taking you through an introduction on polycystic ovarian syndrome. Then we'll talk about the epidemiology, the possible risk factors, the pathophysiology, the clinical presentation, investigations, and management stroke treatment. As a form of introduction, next slide, please. Hello. So polycystic ovarian syndrome is a common hormonal condition that affects women of reproductive age group. It usually starts during adolescence, but symptoms may fluctuate over time. So it's quite common, even though we may not be particularly aware of the condition, because a lot of times the diagnosis is usually made in the four walls of the hospital. But by the time I start reeling out the symptoms, quite a number of us will realize that we either have had some of those symptoms, are presently experiencing those symptoms, or we have someone who has been having complaints similar or that might be suggestive of polycystic ovarian syndrome. So it has been called, or it has been called polycystic. Some people call it polycystic ovaries. Some say polycystic ovarian syndrome, polycystic ovarian disease, polycystic ovarian disorder. It's quite dynamic, and they say it's an heterogeneous disease because it has different ways in which it presents. And should I say it can be creepy? Maybe creepy is the word. Next slide, please. So neither the term polycystic ovary syndrome nor the term polycystic ovarian disease is entirely satisfactory. The condition presents a syndrome in only a few cases, and women with no clinical feature other than irregular menstrual cycles should not be told they carry a disease. A more satisfactory word or term is polycystic ovarian disorder. So, because of the myriads of ways it can present, there has been a dilemma as to how do we particularly fix people in the various syndromes or in the various spectrum of PCOS. So as we go along, we would see the different spectrum in which PCOS can present. So it's a disorder of uncertainty and a kingpin of heterogeneity, in the sense that it has a wide or a myriad ways or extent of presentation. Polycystic ovarian syndrome affects an approximated 8 to 13% of reproductive age group, in the sense that when you have, say, 100 women within the reproductive age group, 8 to 13 out of those 100 women are battling with polycystic ovarian syndrome, and up to 70% of these women actually remain undiagnosed worldwide. So you would agree with me that there is a gap between the symptom, clinical presentation, and eventual diagnosis. The World Health Organization estimates that PCOS affected about 116 million people globally. You see that that's a whooping sum. So it might particularly be commoner than we even thought it was. Next slide, please. So PCOS is the commonest cause of anovulation and a leading cause of infertility. So when we say anovulation, we mean that a woman is not ovulating, anovulation, not ovulating. So I would like to quickly take us through. Okay, let me conclude this before I talk about that. So PCOS is associated with a variety of long-term health problems that affect both the physical, emotional, and even the mental well-being of the sufferers, and sometimes even their relatives. Next slide, please. So now, the risk factors. No, before I talk about these risk factors, I would like to explain the whole process involved in ovulating, menstruating, and eventually getting pregnant and all of that. So usually, when a child attains puberty, the
Dr.
hormones,
Nima, if
there's
you
some,
do not
hello,
mind, hello, can you hear me?
yes, I can. I hope
Yeah,
I'm
if
audible.
you are very audible, but to be more engaging, we would like if your camera is on. I don't know, I think we
Okay,
lost you sometime. Yeah, to engage the participants more. Awesome. Thank you
okay.
very
Please,
much.
can you see me now? But
Yes.
unfortunately, I can't even see myself. I don't know why.
Oh, that happens
But
sometimes. It has to do
okay,
with the
it's fine.
setting. Okay,
Okay,
you can
it's
go
fine.
ahead.
All right. Okay, so um yes, I was trying to explain how, so when a girl child attains puberty, there is a balance. We call it hypothalamo-pituitary ovarian axis, which gets matured during puberty, and the maturity of this axis helps in achieving ovulation, menstruation, and eventually makes the girl a woman using the, okay, it eventually makes the girl a woman using the common man's language, in the sense that when a girl child is able to menstruate, she's able to ovulate, then she can eventually get pregnant if she has sexual intercourse and fertilization occurs. So all of these processes takes a balance of certain hormones in the system. Now, for patients who have polycystic ovarian syndrome, there is some sort of disruption in all of this balance that eventually prevents them from ovulating. And that is why we say that the polycystic ovarian syndrome is the commonest cause of anovulatory infertility, in the sense that ladies who suffer from polycystic ovarian syndrome a lot of times are not ovulating. They also have difficulty having regular menstruation, but we will get to details on that. So a lot of times people will say, at least when we know the cause of a disease, we can avoid it, and so we don't eventually get the disease. But unfortunately, polycystic ovarian syndrome is a multifactorial disorder, and the cause is not known. However, it has been associated with some risk factors. So some of these risk factors are modifiable and some of them are not modifiable, in the sense that we don't particularly have control over some of those risk factors. And then the risk factors are a combination of inherited and environmental factors, which are thought to play significant roles. So we have environmental toxins. So some environmental toxins have been identified as possible risk factors in polycystic ovarian syndrome. And okay. So some of these environmental toxins have been these toxins are substances found in um, paint, some substances found okay, so some of these environmental toxins have been identified to result in hormonal imbalance. Now, I would expatiate a little bit more on these environmental toxins within in a few minutes, but I would like to talk on lifestyle and diet. So a lot of times we realize that our lifestyle, our diets are highly modifiable, and we've realized that women who have polycystic ovarian syndrome are at increased risk of being obese. They have increased risk of having insulin resistance, and they have increased risk of having um, diabetes. So, because of the increased insulin resistance, there is an ongoing hyperandrogenic state because of the polycystic ovarian syndrome that they have. Now, because the ovaries have become polycystic, in the sense that now I have a picture that will show you what the normal ovary looks like. So the normal ovary, when it's time to ovulate, you have some few ovaries trying to get to the size of, no, don't worry, don't change the slide, just let's maintain. Okay. Hello. Yes, thanks for this. So this slide is showing what the normal ovary looks like. So the normal ovary has some follicles, and then we have what we call a dominant follicle. Now, this dominant follicle is what eventually gets released during ovulation. And when this ovum or this egg is released during ovulation, if fertilization occurs during that time, there is a chance of getting pregnant. So you see how smooth, well organized the normal ovary looks like. Now, coming to the polycystic ovary, you will see that there are multiple ovaries. There are multiple um, there are multiple follicles in the ovary, and we don't have anyone that is dominant. So what you have is like different follicles attempting to attain the size of a dominant follicle, but unfortunately they are unable to attain that size, and then the ovarian wall is thickened. And so, in ovulation is some sort of arching. In this polycystic ovary, the wall of the ovary appears to be thickened and arching is difficult. So even if these eggs try to become dominant, a lot of times they don't usually attain that. They are usually not released. So ovulation doesn't occur. And that is why we say that polycystic ovarian syndrome is a cause of an ovulatory cycle. Hello, I hope I'm making some sense. Hello.
Yes, you have.
Okay. So because individuals who have this condition are unable to ovulate, they are not able to get pregnant. I hope that makes some sense. So they just
Yes.
have a lot of ovaries in their a lot of follicles in their ovaries that don't arch, and so ovulation doesn't occur. Now, because they are not ovulating and they have a lot of tiny follicles within the ovary, these follicles produce what we call androgen. Androgen are masculizing hormones that um, have virilizing effects. That is, they have the effects of masculinization. So let me explain. Let me try to break it down. So these androgens are responsible for facial hairs. They are responsible for hoarseness of the voice. They are responsible for they cause acne. And so, because in polycystic ovaries, there is dysfunctional hormonal balance and outplay. There is increased androgen secretion from the ovarian follicles, as well as the adrenals. That's that small gland on top of the kidneys. So now, because of this dysfunctional and imbalance or uncoordinated functions in the hypothalamo-pituitary axis, which I was trying to explain earlier, these individuals have increased androgen secretion. And so when there is increased androgen secretion, they begin to have facial hairs. Some of them begin to grow hair on the chest. There is change in voice. They have acne. So they begin to battle with acne and all of the features that hyperandrogenism can cause. Sorry, please, could you kindly go to the previous slide? Hello? Previous one, please. The previous one. Okay. So, now, apart from PCOS affecting only the menstrual cycle, in the sense that the patient has we call it oligo or amenorrhea, in which there is reduced menstrual flow, or the patient does not even have um, menses at all, or there is reduced frequency. There is also a metabolic effect, in which case, because of the because of the insulin resistance, because insulin has a role in all of the metabolic um, process and breakdown of carbohydrates, fat, and all. So when there is resistance to this insulin, there is a lot of metabolic effects that can follow. So these patients will now have what we call the metabolic syndrome. So apart from having insulin resistance, there is also issues with their fat metabolism. So there is increased triglycerides. This is circulating fat. So they have increased circulating fat. They have increased risk of having hypertension. They have increased risk of having cardiovascular diseases, So it becomes like a spectrum. So because this is there, this follows, that follows, and it becomes like a vicious cycle. I really hope I'm able to make this clear. So the next slide, please. Okay, so apart from all of these factors, some genetic factors have also been identified: family history, individuals with certain genetic predispositions. So, and you would agree with me that some of these genetic predispositions are not modifiable. We really do not have a lot of influence on them. So genes have been identified as possible risk factors for polycystic ovarian syndrome. So some individuals have genetic predisposition to having polycystic ovarian syndrome. Next slide, please. So now in the classification, and this is where you will see the spectrum that we are talking about in PCOS. So and then because of the heterogeneity and because of the fact that it's quite how do I put it? Okay, I think heterogeneity is the word. You will see that we have different classification year in, year out. As researches are ongoing, there is modification in the classification, there is addition and subtraction in what will make you actually eventually be diagnosed or be labeled as having polycystic ovarian syndrome. So now the first classification previously talked about having ovulatory dysfunction and hyperandrogenism. I've tried to explain the ovulatory dysfunction, and I've tried to talk about hyperandrogenism, emphasizing the fact that it involves increased circulation of masculizing or virilizing hormones. So now we have a further classification, which is the Rotterdam, which appears to be quite common. No, the previous slide, please. The Rotterdam classification, which still emphasizes that before you can say that somebody has polycystic ovarian syndrome, the individual must have at least two of these. So there must be evidence that there is hyperandrogenism. There must be evidence that the person has ovulatory dysfunction. Or, so now out of these three, two of it must be present. Or there must be evidence that there is polycystic ovarian morphology. I'll talk about polycystic ovarian morphology very soon. So the most recent classification where we have different phenotypes. So now the fact that somebody has hyperandrogenism doesn't mean the person has PCOS. So there has to be a combination of one or two or more of those symptoms. And then depending on what we find on this in this person, that is what will help us to classify this person as either having phenotype 1, 2, or phenotype 1, 2, 3, or ABCD of polycystic ovarian syndrome. And this is the most recent classification. So now the first phenotype is the one in which the patient has hyperandrogenic evidence or symptoms suggestive of hyperandrogenism. There is ovulatory disorder, and then the patient has polycystic ovarian morphology. That is the phenotype A. Now, phenotype B, the patient has only hyperandrogenism and ovulatory disorder. There is no polycystic ovarian morphology. In the type C, there is hyperandrogenism, there is polycystic ovarian morphology, while in the type D, the patient doesn't have hyperandrogenism, meaning there is no facial hair, there is no acne, there is no hoarseness of voice, but the patient is having issues with ovulating, and on ultrasound scan, we can see that there are evidence of polycystic ovarian morphology. You would agree with me that this condition called PCOS is quite how do I put it? It's heterogeneous in the sense that it can present in different spectrum. So the fact that an individual doesn't have hyperandrogenism doesn't particularly mean that it doesn't have PCOS. The fact that an individual doesn't have ovulatory disorder doesn't particularly mean the person doesn't have PCOS. And the mere fact that, okay, on ultrasound scan, we are able to see multiple cysts in the ovary doesn't mean that you would tag the person as having PCOS. I really hope that is clear. So to a large extent, the diagnosis is actually meant to be made in the hospital by a specialist. So it's not okay when you see one or two signs or symptoms you might be suspecting, but you might think it's PCOS, but it might not be PCOS. So now, in the polycystic ovarian morphology, this is an ultrasound scan findings that can be present in women with ovulatory disorder and oligomenorrhea due to hypothalamo-pituitary ovulatory dysfunction. I think I mentioned this. So let me just show you the picture. The next slide, please. Yes. So polycystic ovaries. Now, it is very important to differentiate between just having polycystic ovaries and having polycystic ovarian syndrome or polycystic ovarian disorder. So now, polycystic ovaries can be found in 20 to 33% of the general population, in the sense that general population with either those that have been diagnosed with PCOS or no PCOS, you can actually find some individuals who have polycystic ovaries, whereas you would find polycystic ovaries in about 80% of women who have been diagnosed with polycystic ovarian syndrome. I hope we are able to catch that difference. So now, what do we see before we say this is polycystic ovarian morphology? Which when an individual does a transvaginal ultrasound scan, or even sometimes a pelvic ultrasound, you are able to see up to like 12 peripheral small sub-centimeter follicles, about 2 to 9 millimeters in diameter, on transvaginal ultrasound scan in at least one ovary. There is increased ovarian size. The ovarian size will be greater than 10 centimeter cube. And yes, the ovarian size will be greater than 10 centimeter cube. The next slide will show you a picture of this. Next slide, please. Sorry, the next slide. I'll come back to this. Sorry, next slide. There is a picture I'm looking for. Okay, so maybe I'm not there yet. Kindly go back, please. Kindly go back. There is a picture I wanted to use to depict the polycystic ovarian syndrome on the polycystic ovaries or polycystic ovarian morphology on ultrasound. But I think I'll get there as we move on. So really, in a healthy ovary where there isn't polycystic ovarian morphology, yes, you can find a few follicles trying to grow to become um, um, a dominant follicle in preparation for ovulation. But in polycystic ovarian morphology, what you see are multiple tiny follicles. They are majorly arranged in the periphery of the ovary. So when you see this up to 2 to 9 tiny follicles with an increase in the ovarian volume, then this is suggestive of polycystic ovarian morphology. And it's important to note that polycystic ovarian syndrome is a form of ovulatory disorder. And in this case, is in the classification type 3, in the WHO classification of ovulatory disorders. Next slide, please. Next slide. Okay, so how do women with polycystic ovarian syndrome present? Now, you would see that I tried to put some percentages in front of this symptom. So this is from the most common symptom that these women present with. So the commonest presentation or the commonest cause of clinic visits in these women is that they are either not menstruating or they are having reduced frequency. So the cycle length will last maybe 60 days. So which means that in 2 to 3 months, the patient might not menstruate. Or the patient can even tell you, in the last 6 months, I've not seen my period. And you know, when you've not seen your period in the last 6 months, the most important thing to rule out is pregnancy. So the pregnancy has been ruled out. So the patient is not pregnant, and yes, she's not seeing her period. So, and then some women may not particularly have ovulatory disorder, in that they are menstruating well, or perhaps they didn't even notice that there has been a change in their menses, because some women sometimes don't notice. But the reason why they will present or the changes is not a reason for them to come to the hospital. Like, they are not so bothered. Okay, I've not seen my period, there's no issue, I'm fine. But sometimes what will now bring them to the hospital is the fact that they've been trying to get pregnant and they are not achieving pregnancy. And you would agree with me that I said that individuals who are having polycystic ovarian syndrome have issues with ovulation. So if you're not ovulating, the chances of getting pregnant is very slim. So hirsutism. Hirsutism is as a result of hyperandrogenism, which is increased masculinizing or virilizing hormones in circulation. So because they have this increased androgen in circulation, they tend to have um, facial hairs. They can have hair on their chest. You can have yes, majorly facial hair on the chest. So, and which was not previously there. So those are some things that as a clinician one will need to rule out. Some women, as a form of as an will I say hereditary, it's hereditary that they have facial hairs. So you see some Igbo women, this is not any form of discrimination. They are very hairy, to such an extent that they would have beards and they will have to be cutting it. But that doesn't mean that they have PCOS. I don't know if you understand. So there are a lot of conditions that can mimic PCOS that is not particularly PCOS. So it's not something that one will sit at home and make a diagnosis. But it's important for you to be aware that, okay, so symptoms, these symptoms might be a manifestation of PCOS, and let me seek medical help. So quite a number of people present with troublesome acne, and this is also because of the circulating androgen. Then you would see the percentage, about 30 to 50% of individuals who present because of acne, and you agree with me that this is quite high. Then obesity, because of the hyper insulin resistance state in PCOS, because of the metabolic disorders associated with PCOS, there is dysfunctional carbohydrate metabolism, steroidogenesis, which is majorly cholesterol breakdown, that which is fat. There's issues with fat breakdown and all of that. So these women tend to be obese, particularly truncal obesity. So sometimes you see adolescents presenting to the hospital, and they have all of the classical features, from being obese to having facial hairs to having trouble with menstruation. So all of these features are features that are commonly seen in individuals with polycystic ovarian syndrome. And sometimes too, in 30 to 50% of cases, they could actually achieve pregnancy but have recurrent miscarriage because of the underlying metabolic disorder. So there is poor glucose control. There is sometimes there is underlying hypertension. There is hyperglyceridemia and all of that. So all of these unstable metabolic states can result in recurrent pregnancy loss. And interestingly, some women may be asymptomatic. That is, some women may not even have any symptom at all. Next slide, please. So, menstrual issues. 50% of women present with oligomenorrhea, in which case they have um, um, increased intervals in their menstrual cycle. That is, maybe you can confidently say previously that my cycle length is 28 days. And then when you are asked subsequently, because of the evolving PCOS, you would be finding it difficult to tell what your cycle length is, or you would say, my cycle length now, in the last 3 months, I've not seen my period, or they would have this period of amenorrhea, no menses at all, and then by the time they are going to be menstruating, they are going to have heavy menstrual bleeding that sometimes will require hospitalization, because in the polycystic ovary there is increased estrogen secretion too, because of the um, multiple follicles. There's increased estrogen secretion. The increased estrogen secretion causes endometrial hyperplasia. So when I talk about endometrial hyperplasia, I mean that the inside of the womb, I believe we know that during menses, what happens is that because fertilization has not occurred, the inside of the womb that has grown, there is proliferation in the endometrial lining, which is the lining of the womb, to help carry pregnancy. So if fertilization does not occur, this lining of the womb will shed. But because there is no abnormality, the shedding is moderate. The woman will menstruate for maybe 5 to 7 days, and that's the end. But in women with polycystic ovarian syndrome, there is excessive proliferation of that uterine lining. And then sometimes there is now accumulation. So they will not menstruate the first month, they won't menstruate the second month, they won't menstruate the third month. By the time they will be shedding, they are shedding heavily. So they will be having heavy menstruation. And sometimes this might require them being hospitalized. Sometimes it might require being transfused. So there is associated hormonal imbalance. I think I've been able to say that. And then there's increased circulating testosterone. This talks just tries to give a pictorial idea or pictorial representation of what we see in women with polycystic ovarian syndrome. So there is excessive hair growth, weight changes, and trouble losing weight. On ultrasound scan, there's polycystic ovary. They complain of missed period or irregular menses. They have male pattern. Now, because of the increased circulating virilizing or masculizing hormone, some women even lose their hair. Some women suffer from alopecia, baldness, which is because of the hyperandrogenic state. And then there is insulin resistance. So some women might even eventually need to be on hypoglycemic drugs, that is, drugs to help reduce blood sugar. And so their management is usually multidisciplinary, involving a lot of health workers, a lot of specialists, not just one doctor. So there is fatigue, there is acne, there is mood swing, there is issue of infertility. Now, you agree with me that all of these symptoms have effect on the emotion of the woman, has effect on her self-esteem, has effect on her mental health. Because for a woman who is obese, obesity in itself has mental health implication, because there could be associated bullying, there could be associated low self-esteem, there could be associated stigmatization, and the effects, mental health issues that follows. In our environment, if a woman is infertile, all of the drama that can be associated with it. It has its own emotional effect. It has its own psychosocial effects. All of this emanating from PCOS. Now, for a woman who is growing facial hair or having terrible acne, you would agree with me that that can also be troubling. Because imagine having to make videos and, you have to show your face full of acne and all. Some people can't hide their comments, and they will make undue comments about that. And that is in itself can affect the woman's self-esteem. So you would agree with me that all of these myriads of um, affectation of physical health, affectation of your emotion, affectation of mental health, as well as the psychology of the woman, all of it emanating from PCOS. So you would agree with me that it's a multifaceted condition that requires, one, being aware that it exists, and then two, knowing how to seek the required help when the need arises. So now, in the management of patients who have polycystic ovarian syndrome, it's important to take history. And in the history, what one wants to do is to ask all of those symptoms that I have said. You want to ask, okay, a woman comes, I presented in the hospital today because I've not seen my period in, like, say, 6 months. Okay, so if a woman comes and says she has not seen her period in 6 months, I want to know, okay, have you been sexually active? She says yes. Okay, I want to ask about um any recent history of weight gain, any recent history of changes in voice, um, facial growth of facial hair or hair on the chest. You know, I want to take a good history to diagnose, one, to make a diagnosis of PCOS if that is what I'm thinking, and two, to rule out other differentials, because there are so many other conditions that might mimic or appear similar to PCOS that might not be particularly PCOS. So the essence of taking a history, which is what your doctor does. So when you go to the hospital and they start asking you all the questions, I get patients asking that, why are you asking about this? Do you have to know about this? The essence is, one, to coin down the diagnosis and to rule out other possible causes of your symptom, so that we will not just say, she has PCOS because she has one or two or three symptoms, without ruling out other possible causes of that. So now, in examining these patients, I want to check, first of all, her weight, her height, so as to be able to note if she's obese. So sometimes you have women coming with they might be overweight, it might be the type 1, type 2 obesity, or even morbid obesity. So during the examination, I'll be able to tell that acanthosis nigricans, which are hyperpigmentation of the skin, can be seen on these women. Of course, the esthetism that I've talked about, the acne, are features that can be seen when examining the patient. And then we go ahead to examine all of the other symptoms, because these patients might even have elevated blood pressure. She might even have increased blood sugar and all of that. So having done an examination, then you want to do investigation. A lot of times when people present in the hospital and they are told to do investigation, it's always like, why are we always asked to do this investigation, do that investigation, and all of that? But the reason to do all of this investigation is, one, come down on the diagnosis. Okay, I'm thinking this is PCOS. I've told you that there are type 1, that's the phenotype A, B, C, D. Okay, where does this woman belong if it is actually PCOS? It's from investigations, and as well as yes, majorly from investigations, as well as the history that you give that would help with that. But if I want to rule out other things, okay, is this woman pregnant? Okay, you came to me, you've not seen your period in 6 months. I have to do a pregnancy test to be sure that, are you sure it's not that you're even pregnant? And then I have to rule out thyroid disease. And in ruling out thyroid disease, we're going to do a thyroid function test to see if it's, because thyroid function test, thyroid disease can also present with issues with menstruation. So it could be heavy menses, it could be reduced menses, it could be amenorrhea too, depending on if it is hypo or hyperthyroidism the woman has. So some women have hyperprolactinemia, which is preventing them from menstruating. Because in hyperprolactinemia is seen in patients who have um, how do I explain this now? Expressible galacturia, in the sense that when you press their nipple, they are not breastfeeding. They are not breastfeeding, but they have milky discharge from the breast. So when you are having expressible galacturia, there is a high chance that the woman will not menstruate. So if she's not menstruating and she presents in the hospital, it will be unfair to tell her that the reason why you're not menstruating is because you have PCOS. So not all oligo or amenorrhea is PCOS. I hope I'm making some sense, because I'm trying to get somewhere. So hyperprolactinemia, so there is a need to check for the prolactin level if it's not high, and then to also assess for congenital adrenal hyperplasia, which is a condition that can also present with elevated level of androgen, and the woman will have exotism, will have hoarseness of voice, would have hoarseness of voice, facial hairs and all of that, alopecia, hair loss, So there is a need to rule out all of these other possible causes before we cone down the diagnosis that, okay, having ruled out all of the differential, this woman has PCOS. And that is why it is not a thing of, and when I did not see my period, this is the drug they gave me, you to use it. Your own oligoamenorrhea may be because of PCOS, whereas your neighbor's own may be due to hypo or hyperthyroidism. So it's not something that you sit down at home and diagnose. Okay, previous slide, please. I think that was the picture I was looking for. Yes. So this picture tries to show what we see in PCOM, which is polycystic ovarian morphology. You see that there are so many tiny follicles in this ovary. And unfortunately, none of them will get big enough to arch and release an ovum for fertilization. So they are just very tiny, attempting to grow, but they don't eventually grow, and they are not eventually arched. So next slide. And this is usually seen on ultrasound. So one of the investigations you'll be asked to do is to do a transvaginal ultrasound scan. Previous slide, please. Okay, yes, okay. I think I've talked about the differentials. So if it's not PCOS, what else can it be? I've talked about that. So now the treatment is not one cap fits all. It depends on what the patient wants, the symptom the patient is presenting with, and majorly the desirability for fertility too. So treatment can range from lifestyle modification up until use of medications and then eventual surgery if need be. So now in lifestyle modification, major things we emphasize on here are the diet as well as exercise. So I don't know if I mentioned in the possible causes that some imbalance in the um, um, prebiotics, that's organisms in the alimentary canal, have been identified to also increase the risk of PCOS because there's increased risk of inflammatory disorders and all of that. So, and all of these are have been identified in taking in of junks, highly sugary diets, and all of that. So, a lot of times when these women present and they are able to have effective dietary and lifestyle modification, majorly weight loss. So in achieving weight loss, we advocate for diet modification and exercise. A lot of times, by the time these women shed weight, they are able to achieve normal menstruation. And sometimes some people even eventually achieve fertility. So it's not like every time there is a diagnosis of PCOS, then it has to be drugs or it has to be surgery or stuffs like that. A lot of times we want to start from lifestyle modification. So we tell these women, reduce carbohydrate, reduce refined sugar intake, take more of vegetables, take more of fruits, exercise, and exercising, you have minimum of 30 minutes a day, not particularly rigorous exercise, but you know, moderate exercise. So exercising, eating healthy, and not eating large volumes. So because of our environment and the economic reality, we see that a lot of times when we want to eat, we take a large portion of carbohydrates. So you have this bowl full of rice, and then you have your tiny stew just to, stir and eat something. But in this case now, because there is a need for these women to shed weight, it is important to take small portions of carbohydrates. So if you want to take rice, it's not like we are saying don't eat, but take smaller portions of carbohydrates, increase your vegetable and fruit intake, then increase exercise. So part of the investigations that would have been done then is to have screening for diabetes, because if this woman is diabetic, it's important for her to be co-managed with the endocrinologist. So there is the role of the endocrinologist, there is a role for the dietitian. So it's not only the the gynecologist that would manage this patient. And then if the woman has been identified to be having low self-esteem, some people even go to such an extent as having suicidal ideation because of stigmatization. Adolescents who have acne, who are obese, are usually stigmatized, they are bullied. So there is usually the psychological effect on them. So there might be a need for them to also be reviewed and managed by the clinical psychologist or behavioral scientist. So now, weight loss improves ovulatory and fertility rates
Dr.
about
Nima,
5.
if you would check your personal chat, please.
Okay, okay, thank you. So it's been identified that only lifestyle modification, diet, and exercise restores ovulation in about 75% of women. That's a whole lot. And it decreases yes, well, all of these are the hormonal imbalance that is associated. Then it decreases androgen production and reduces the insulin level. So, which means that lifestyle modification has a huge role in the management and sometimes even the prevention of polycystic ovarian syndrome. So if there is anything we are going to be taking home here, is for us to try to ensure that we manage ourselves so that we don't gain weight excessively. With or without PCOS, obesity in itself is a disease. So ensure you eat healthy, majorly balanced diet, avoid junks, refined foods, stick more to healthy diets, fruits and vegetables majorly, and then most okay. So weight loss is most effective in obese patients, and it reduces the risk of type 2 DM. And that's diabetes. Okay, so next slide, please. So now, if if an adolescent comes in and a diagnosis of polycystic ovarian syndrome is made, to a large extent, she might not even be thinking of getting pregnant at that time. So the goal at that time is not pregnancy. The goal is, okay, she wants to menstruate, she wants to gain, she wants to be able to have a regular menstrual flow. And so she'll be managed along that line. Helping her to counseling on the dietary modification, the exercise. Sometimes you place on um, combined oral contraceptive to help with regularization of the period. But like I said earlier, a lot of times by the time these individuals shed weight, they are able to achieve normal menses. Now, next slide, please. For individuals who are desirous of fertility, it's important to note that there is a need for them, yes, there is a need for them to be placed on medications that would help with sugar control. Either they have poor glycemic control or not. As in, if a woman is desirous of pregnancy, a lot of times they are usually placed on hypoglycemic agents like metformin, as well as um, medications that would help them with ovulation. I told you that a lot of times women with polycystic ovarian syndrome don't ovulate. So because this woman is desirous of pregnancy, you want to help her ovulate, having ensured that she has lost adequate weight, and then you are now moving on to helping her to achieve pregnancy. Next slide, please. Okay, so I think I've talked about this. So for individuals who present with complaints of acne, you want to help them manage the acne. So a lot of times too, management could be based on symptomatology. So a lady can present and the major problem she has is the acne. So we would give medications that will help with the acne. Some women is the hirsutism. There are ways to manage the hirsutism, and that I've mentioned here. There are options of management for hirsutism. Next slide, please. All right, okay. So thank you very much. So in all, I would like to emphasize the fact that polycystic ovarian syndrome appears to be a disease that may not be particularly preventable because the cause is unknown. However, the few identified risk factors, which are talked about earlier, and majorly emphasis on obesity, individuals who have family history of polycystic ovarian syndrome, individuals who have genetic predispositions and all of that. So the major thing is to identify the modifiable risk factors and work on them. And in this case, is majorly the diet and lifestyle modification, which is exercising. And then to have a high index of suspicion, if you feel that you're not menstruating well, or you feel that you've been battling with infertility for a while, there might be a need to be evaluated. Perhaps you're dealing with polycystic ovarian syndrome. Thank you very much as I await your questions and clarification. The last slide, please. So the last slide, please. Teal is the color for polycystic ovarian syndrome awareness, and the month for polycystic ovarian syndrome awareness is September. I think there's another slide after this just to show something on polycystic ovarian syndrome awareness. Yes. So it's sometimes it appears to be a battle for some people because of the associated psychosocial effects. Thank you very much.
Thank you so much, Dr. Nima. It's been a very wonderful session, and I believe every one of us we picked one or two lessons, and we picked one or two more information regarding polycystic ovarian syndrome. That was awesome. Thank you very much once again, Dr. Nima, and thank you to everyone who has stayed so far. Without further ado, we're going to be moving on to. We're going to be moving on to our plenary session. And if you ask me, I think this is a very interesting part of it because there is going to be cash prize to be won. Can everybody hear me? I hope you can all hear me.
Yes, we can.
Awesome, awesome. So this part is going to be very interesting, and I want us. It's going to be more like a fastest finger first, but I'm going to share something on the chat platform now. Okay, we're going to quickly present a PCOS game. That's what we call it. Just a minute here. Okay. So if we come here, this is our plenary section. This is Think You Know PCOS. Why not play the PCOS game? So basically what this is about is just to strengthen our knowledge of polycystic ovarian syndrome that Dr. Nima already put us through. We're going to be asked a couple of questions. I'm going to post it on the chat platform so we can all see first. Let's see. Let's do that now. V. Yeah, I think everyone should be able to see the link right now. I believe we all can. And I am going to share the screen to show you what exactly I want us to be doing in 1 second. So if you have any questions, you can start typing them on the chat as well. We would get the questions just right after we have this plenary session. Yeah, we may see some questions that seem like, oh wow, this is for a doctor to answer. No, they're very, very simple questions, and the game is all about just moving fast. If you're not able to answer one question, just move on. Move on so you can win as much as you can. Okay, so if you click on that link, this is what you would see. I believe are all with me. And the only thing you need to do is click to start. And I'm going to share the rules of the game with every one of us. So these are the rules. You are going to say couple of questions. All you need to do is answer each question as fast as you can. As I said, if you do not know the answer, just move on, okay? If you get it wrong, try again with a new question. This game has lots of flowers to boost your score. If you see these flowers, try as much as possible to click on them. Get 5 extra points for each flower you get, and 1 point for a correct answer. If you are able to reach the finish line, you will get 5 bonus points. Okay, I hope we're all with me, right? So pretty much it's simple. You get as much flowers, you get as much questions within 60 seconds. So today we're going to try to see how many of us can beat these scores. These are the high scores by players of this game worldwide. I know we would be able to get people around 50, 40, 30s, but let's see if we can actually get someone who is going to beat Susan at PCOS game score, okay? Let's see if WHTI can produce that person. So let's go back. I'm just going to show us what the interface of the game looks like so everybody knows what's going on. I'm going to launch when we're going to start so there is no foul play. Once it's 1 minute, your game is going to end. What I need you to do is to share a screen grab of your score, and then we would see what. So when you click on play, it's going to show your name, and this is like what you have to do. Okay? So for me, I'm choosing this, I'm clicking this question. I know Dr. Nima mentioned something about acanthosis. I'm just going to say true. Let's see. Oh, yeah, I got that question right. It's going to go to the next question. Perhaps if I get the score wrong, let's say I'm choosing false here, and I get it wrong, I'm not going to be discouraged. I'm just going to move on to the next question so that my time, I'm not going to go past the 60 seconds and I can still win our cash prize. The first, second, and third people are going to get some prizes today, okay? So I'm going to launch and I'm going to time. Once my time is up, I expect that we share our screens to show our answers. Do we all follow? Do we all follow? Okay, I see we have questions already from participants, but can anybody hear me? Is anybody here? Awesome. Okay, I see thumbs up. Thank you so much for that. So if you want to go on your screens now and click on that link, does anybody have any question to ask me, any clarifications before we go on? Okay, I believe not. All right. I can't find the link here. The link is on the chat platform. I'm gonna post it again. Okay, I just posted the link again. Just look for WHTI and you would see it. I believe we've all seen the link. Awesome. So right now, I think it's about time for us to start. So everyone can go answer as much questions as you can. Share your screen with us. The first, second, and third would get some compensation for the data they've used to join us today. Okay? All right, let's all go. I'm going to stop us, and the first three people, I'm going to watch who post their results first. So there isn't going to be room for some, by the way, going ahead to answer more questions after the time has gone up. If I have not sent, if I haven't asked us to post our responses, you can try again. There is room to try as much as you can. Can you resend the link? The link keeps disappearing. Okay, I'm going to pin it right here. Okay. Yes, you're not expected to unmute your mic. All I need is for us to share your score. A screen grab of your score is all I need. I'll keep posting the link. for everyone to be able to. Yeah. Okay. Yes. Good. The link is for the game I have on my screen. Is for everyone to participate, and whoever takes first, second, or third is gonna get rewarded. Okay. All right. So I'll say it's time for us to share our results for everyone who participated. Remember, there is a cash prize to be won. You don't have to get. How do we get the record for people that are just joining? Yes, we are going to send. You can drop your email addresses, or we actually do have them. If you want us to send the recording of today's session, you can drop your email address, or you can send us an email. Okay, I would send email address. It's whtinigeria@gmail.com. I will post that right away for us to actually see. Yes, whtnigeria at gmail.com. We will be replying all emails we get from here. Okay, I believe everyone. Oh, okay, I see scores already. How do we share screen? You can just use your phone to take a picture of your screen and send it to the chat. Okay, I see people already posting their results. Yeah, I see good scores, good ones. Everybody's doing great. So we have silver. You can try again. You can try again. There's room until I say stop. Awesome. Awesome. Good. Great. I'm looking for who is going to beat 22. I've seen 22 as the score. Remember, we're trying to get somebody in the 70s. Okay. There is still room. Okay. Amina, can you kindly collect the scores? Let's see how people are doing. And then we will go right to take the question.
Okay.
We have 2 more minutes for anyone who wants to try again or wants to try the game. There is still room. At 9:50, we're gonna start 9:50, that's my time, pardon me. That should be around 5:50 p.m. West African time. We are gonna stop and we'll collect the results and we'll have our winners for today. Okay. I'm going over the chat. I'm going over the chat to see who has any questions. I have seen one or two very well presented and informative slides. Okay. All right. Can someone with PCOS get pregnant? That's somebody's question. Okay. Okay. 21, 22, 33. Great. We have somebody who has 23. She had the gold. Can anyone beat her in the last 1 minute we have? 1 minute. This is great. You know, the important and interesting thing about this is that you can always go ahead and check out this again, even at the comfort of your homes, in your own comfort zone. You learn more. Wow, we have 38. Awesome. Now, this is getting really competitive. Do we have ooh, 35? Okay, all right, it's time up. We're not taking any more responses. That's the end of the plenary session for today. Thank you so much. Karima, I think we lost Karima. I couldn't get across to her. Are you back to taking the questions, Karima? Are you there? If you're there, can you say something? Okay. I think I'm just going to stand in for her till she's done. Awesome. Everybody has done a very, very great job. Everybody tried. I've seen gold, I've seen silver, I've seen platinum. For there was somebody who shared only the finish line. You didn't share your score. So if you want to share your score, I think that will be Ngige. If you want to share, oh, that's 47. Awesome. Okay, okay. I'm just gonna sneak out of this place so that I'll let Amina, who is the co-founder, collect the result and tell us what our first, second, and third positions go to. So I'm not gonna be biased. All right. Okay. Dr. Nima, are you ready for the questions now?
Yes, please.
Awesome, great. So I have the first question. We are taking the questions now. Everybody back to the webinar, please. Game is over. Back to the webinar. Okay, so what we're gonna do now, we're gonna take our questions. If you have any questions whatsoever regarding polycystic ovarian syndrome, the topic that has just been described, you can either post it on the chat platform, and if you want, you can use your virtual hand. We can call you to ask your question directly if you're more comfortable doing that. So we have some time for that, and I'm going to go ahead to the first question. And if you don't have to have a question, if you have a comment to share, if you have lived with PCOS and you're doing better, if you're going through the journey of PCOS and you want to share some things, we have a minute or two to spare as well. You know, we are here as a shoulder for everyone. Women's Health Triangle Initiative. What we want is a resting shoulder for every woman. We want a better everyday for every woman when it comes to our health. So, on that note, the first question, Dr. Nima, I have for that is here is: can someone get pregnant with polycystic ovarian syndrome?
Okay, thank you very much for the question. Yes, I think I mentioned it in my slide that a woman can achieve pregnancy with PCOS. And um, for some women, as soon as they are able to cut down on their weight, their menses resume and they are able to achieve pregnancy. For some women, there will be a need to place them on medications like metformin and then go ahead with ovulation induction, because I mentioned that one of the issues with polycystic ovarian syndrome is ovulatory disorder. So there might be a need to help with ovulation induction and then timed intercourse. And we've recorded great success, you know, with that, taking oral hypoglycemic agents like metformin, ovulation induction, timed intercourse, we've been able to record great success. But if for any reason this appears not to be working out, apart from ovulation induction medications, there is room for, I mentioned surgical management, which is the ovarian drilling. So that can also be done. After ovarian drilling, some women have recorded success with ovulation and they can achieve pregnancy. And then if at the end of the day, all of this seem not to work out, then there is room to have assisted reproductive therapy, in which IVF, that's in vitro fertilization, will be an option. So it could be the patient's egg or a donor egg, but a lot of times there's still room for egg retrieval, even with polycystic ovarian syndrome. But that's usually a last resort. We have achieved great success with oral hypoglycemics and ovulation induction. So yes, a woman with PCOS can get pregnant.
Okay, so I'm going to re-echo that. Yes, the answer to your question is yes. A woman with polycystic ovarian syndrome could get pregnant. Just needs to seek care, talk to a doctor, talk to a fertility expert. Thank you, Dr. Nima, for that. The next question. This person is talking related to nutrition. She's asking, does eating bread or flour-based food products affect a patient with PCOS? So this patient already has PCOS, I assume, and is asking, should I keep eating my bread, my white bread, or my pasta, anything related to flour?
Okay. To a large extent, I emphasize the importance of healthy eating, and I also emphasize the importance of cutting down on refined foods. So, I wouldn't say that we should go off bread completely, but what I would say is that reduce carbohydrate portion. So, instead of taking bread, say, every day in a week or 2 times in a day, you can reduce your bread intake to maybe twice a week. And you take your bread with vegetables, or take your bread with, it doesn't have to be at the same time. Take bread, but make sure you take fruits and vegetables too. Adequate fruits and vegetables. Cut down on refined foods, cut down on high sugar, cut down on sugar intake, and then reduce carbohydrates. So I won't particularly say stop consuming. I would rather say eat in moderation. So reduce your carbohydrates intake drastically, increase your intake of fruits and vegetables, more majorly.
Awesome. Awesome. Thank you so much, Dr. Nima. I believe the answer is very clear. Third question: is bleeding continuously for 6 months a symptom of PCOS? I think this person probably missed that when you were talking about it. So if you want to re-echo that as probably a symptom of PCOS or no, is bleeding continuously for 6 months a symptom of PCOS?
Okay, so like I said, that PCOS can be creepy, or will I say, is multifaceted. It can appear like so many other conditions, and it may not particularly be that condition, and it may not be necessarily be PCOS. So, bleeding, prolonged bleeding or bleeding per vaginum for 6 months may or may not be PCOS. But one cannot single-handedly hold on to bleeding per vaginum to make a diagnosis of PCOS. You would see that I mentioned some criteria for the diagnosis. So, in individuals who have ovulatory dysfunction, because they have periods of amenorrhea, that is, periods when they are not ovulating, I'm sorry, when they are not menstruating, but there is high level of circulating estrogen, which would make the lining of the womb proliferate more. That we call it endometrial hyperplasia. And I think one of the things I didn't mention is that apart from all of those complications that PCOS can cause, the metabolic syndromes, the mental health issues, it can also increase the risk of endometrial hyperplasia and even endometrial cancer. So, and diabetes in its own self is a risk factor for endometrial cancer. So, and endometrial hyperplasia, endometrial cancer can present with prolonged bleeding per vaginum. So, yes, PCOS can cause prolonged bleeding after a period of amenorrhea. However, you cannot single-handedly hold on to bleeding per vaginum as a criteria to diagnose polycystic ovarian syndrome. So my humble advice is for this person to go to a specialist hospital for proper evaluation and management. If an individual has submucosal fibroid, it could cause heavy menses, and that would not even cause bleeding for prolonged bleeding, like up to 6 months or the period the person said. So I think this individual needs to be properly evaluated. So please, I wouldn't say this is PCOS until you are well evaluated. Thank you.
That was a very, very smart way of answering that question. Okay, so to the question, once again, you have the knowledge, you have the information you need. You just need to make use of it and direct it to the right quarters. So you can, yeah. One thing WHTI also does is after these webinars, if you need more specialized care, you can send us an email. You can reach out to us. we do referrals. So we can refer you to who would be able to help because, as I said, we are here to make sure every woman has a better everyday. Now, the next question I have here is a bit lengthy and it's in three portions. Okay, this person is asking what kind of food can we eat and what have we to avoid. I think we already answered that because before the questioner types in a question. The part B of the question, which I'm not very clear on, is this patient is saying she has some level of hormonal imbalances with the PCOS and she has been told to take bromocriptine, which I have done. That question is not complete, but she's saying the regular menstrual period has been coming on a monthly basis. But the question which I'm able to pick here, she's asking, can PCOS make one have odor during intercourse? So maybe during sexual intercourse, I assume, can being diagnosed with PCOS make you have symptoms of can make would it make you perceive some odor when you are engaging in sexual intercourse? Dr. Nima, if you're saying something, we
Okay.
cannot hear
Hello.
you. Hi.
Okay. So considering about the diet, I think I've mentioned that ensuring you
Yeah.
eat healthy is the hallmark. So cut down on carbohydrates, cut down on sugar, refined food products, healthy living, diet, exercising, avoiding sedentary lifestyle, avoiding exposure to chemicals. I was trying to explain that then, that some chemicals have been identified to be endocrine disrupting chemicals, and they are found in insecticides, pesticides, and all of that. So if you have to use all of those products, you have to make sure you cover your nose properly so you don't inhale them regularly. Do you get? So now, if a woman is having um, issues with menstruation and she's given bromocriptine, then it's very likely that she has hyperprolactinemia, which is not PCOS. I told you that hyperprolactinemia is actually a differential. It's something one needs to look out for if a woman presents with amenorrhea, as in when a woman comes and says she's not menstruating. Hyperprolactinemia can be a cause, and in your case it appears like that is what you are being managed for. Now, having odor during sexual intercourse, now I must emphasize here that every woman here who has not had pap smear done should try to get pap smear done. Have a cervical screening, please. um Cervical cancer is one of the preventable cancers, is one of the preventable gynecological cancers. When I say preventable, I mean absolutely preventable and curable. But what is needed is early diagnosis. So now, one of the features that can present in cases of cervical cancer is copious foul smelling vaginal discharge. So this person has to be able to delineate, is it only during sexual intercourse you have this vaginal discharge, or this malodorous discharge, or you have malodorous but regular malodorous discharge. Now, if it is during sexual intercourse only, well, which is very unlikely, if you're having malodorous discharge, there is a need to be evaluated. You might just need to do high vaginal swab MCS and then you are treated. Maybe you have some ongoing infection down there. But it's also important to ensure that you are screened. Pap smear should be done every 3 years, and human papilloma virus testing should be done every 5 years as a screening test for cervical cancer. So please don't take anything for granted. It might be as subtle as having foul smelling discharge. And cervical cancer can also present with having bleeding postcoital bleeding, and it can be asymptomatic, hence the need for screening. So I really cannot tell why this individual is having discharge during post intercourse, but there is a need to be evaluated. It could be an ongoing infection out there, down there. There might be a need to get yourself screened for cervical cancer. Thank you.
Awesome. Thank you very much. At this point, I'm also going to mention that WHTI, our last webinar was on cervical cancer. If you want the recording and slides of that as well, we have it handy. Again, we want to make sure every woman out there has a better and healthier day every day of our lives. We have seen a lot of bulk requests for sponsoring people with health conditions, female health conditions, preventable health conditions. And that's why we are churning out this knowledge for everyone to be adequately informed and take charge of our health. Thank you, Dr. Nima, for answering that question extensively. The next question, which I think would be the second to the last one I have, is: does PCOS negatively affect pregnancy? This person is expatiating for she says, like, will there be complications during pregnancy or during childbirth? So this person has had PCOS and then fortunately got pregnant. Will there be complications during the pregnancy, or would it even be when I'm about to have the baby?
Okay, that's a very relevant question. So, like I said, that PCOS is associated with metabolic disorders. So, individuals with PCOS are at risk of having diabetes. Some would have pre-gestational diabetes, in which case they already have diabetes even prior to pregnancy. And some may have gestational diabetes, in which case prior to pregnancy they were not diabetic, but in pregnancy they were diagnosed to have diabetes, but the range of derangement in the sugar control is within the range of gestational diabetes, because some women are picked in pregnancy to be diabetic, but their sugar range is showing that this is an overt diabetes. That is, they have had this diabetes even before pregnancy. So I believe that you've registered in a center where you'll be well managed. Screening will be done, and if you are picked to have any um, evidence of gestational diabetes, you'll be properly managed. So gestational diabetes is associated with its own pregnancy, delivery complications, but if well managed, it shouldn't be something to be worried about. So I think the most important thing is to be in good hands.
Okay, make sure you are in good hands. Avoid quackery. Avoid online virtual drug sellers. All of those that seem like this is not professional. Please and please and please avoid them. Avoid counterfeit services in whatever form that you can. Thank you so much. And the last question which I have, and this is really direct. So she's asking: is Pap smear the same with cervical cancer screening? Is it the same thing as cervical screening? So because I know some people they do cervical screening routinely here in this part of the world. Is it the same thing as pap smear? This person wants to know.
Okay, so pap smear is one of the methods of screening for cervical cancer. Well, maybe a bit common, but in our environment here, where it's a low resource setting, we have other methods of screening for cervical cancer. We have visual inspection with acetic acid. We have visual inspection with glucose iodine. We have the HPV testing, which is quite expensive, but pap smear, we've had a number of times state government, NGOs have done pap smear for free, but it is a test that can be done even as an individual. I don't think it's so expensive, but it's one of the methods of screening for cervical cancer. And it is different from high vaginal swab MCS. It's different from high vaginal swab. People tend to mistaken that. High vaginal swab involves taking a sample of your discharge, the vaginal discharge, to be cultured in the lab so that you'll be treated for whatever infection that is going on down there. However, pap smear tries to scrape cells on the cervix for cytology, and then diagnosis is made and further treatment can be done. So they are two entirely different things, but pap smear is a screening method for cervical cancer. Thank you.
Awesome. Thank you very much, Dr. Nima. So, if you've had a cervical cancer screening done, and they told you it's Pap smear, you have already had. If you've had Pap smear done, you have been screened for cervical cancer. I think that's a more direct way to mention it. Thank you, everyone. So far, it's been very, very enlightening, and we really appreciate everyone's patience. We appreciate everybody's contributions and participation. We would say that we've mentioned so many other things today, talking about screening services, talking about a lot. And I'm sure some people are wondering, this is so awesome. How can I be part of these people? Volunteers do not necessarily have the time, they just have the heart. So if you have the heart to volunteer with us, we are very, very open. We are taking volunteers, graphic designers, videographers, photographers. We have physical health services as well. You may even want to volunteer your time or resource or money, because we also do some screening. So if you want to sponsor people and you want them to be healthier, for sure, you just have to reach out to us. I already posted our information on the chat platform. Here it is again for your view. If you have any questions at any time, it is better to send us an email address. So at this point, I'm going to give room to Amina to let us know who did well. Everybody did very well, but who are those going home with our cash prizes today? So I think at this point, I'll reveal what the cash prize is. The first person gets a cash prize of 5,000 naira, just to compensate our data. The second has 3,000 naira, all in naira form. I think we can convert those to dollars, I know. And then the third person gets 2,000 naira to go home with. So, Amina, do you want to reveal who our winners for today are?
All right. Thank you everyone for participating in the PCOS game. It was really interesting. I've been seeing such great scores from most people. It shows we really did follow through with the lecture. So here I have Balkis Salami with a score of 35. And that seemed like the third highest score. So Balkis Salami 35. Then there's
Yay, Balkis will be so excited. Okay.
Then there's Rashidat Olatunji 38. Yeah.
Okay. Wow.
38. And then we have the champion. I'm sorry if I didn't pronounce your name right. I'm really sorry, but I'll try to. Akumachuku Ngige. Am I right? I'm sorry about that. So with a score of 47.
Wow.
So that's like the highest one we have here.
Oh,
Thank you all
wow.
very much for participating. It shows we are all
That's
attentive.
Thank you so much, Amina, for doing that. I'm sure she's probably somebody that can work with Heineck. I'm sure she did not. It was very free and fair. All right, thank you so much once again, Amina. Thank you so much to everyone who participated. For those she mentioned their names, if you want to send your account details personally directly to WHTI on this chat platform, or better still, you can send us an email. That's for more privacy. You can send us an email containing your banking details, and be sure to hear from us as soon as possible. Normally, I should be ending this webinar this moment, but we have two more questions, and I believe it will just be fair. Dr. Nima, do you have time to take two more questions, please? If you're saying something, I can't hear you.
No problem. Please go ahead with the
Awesome,
question.
awesome, awesome, awesome. So this person has two questions, but I'm going to make it in one. Does PCS cause miscarriage, and how does one know she's not ovulating? I think that's very important. How do I know? You've been saying a lot of anovulation and ovulation. How do I know if I am not ovulating? Does
Okay.
PCS cause miscarriage, and how do I know if I am not ovulating?
Okay. So I tried explaining previously that because PCOS is associated with obesity, it is associated with some metabolic disorders like poor glycemic control. So there is high level of circulating glucose. And all of these can result in recurrent miscarriage. In short, it can result in um, congenital abnormalities in the babies if the diabetes is not well managed. So yes, it can result in recurrent miscarriage. It can result in um, babies with congenital abnormalities. It can, if glucose is not well managed, if the diabetes is not well managed, it can result in stillbirth. So that is why it's important to be in safe hands. Then the second question was what, please?
How do I know if I am not ovulating?
Okay, so um sometimes the honest truth is that you might not know. But there are some people who have been ovulating previously who now notice, like some ladies will tell you, I have mid-cycle pain. You know, they have this increased slimy discharge during ovulation. So if you've been having that before and then you now notice that it has stopped, then you are noticing all of those symptoms that we mentioned, it might just mean that maybe you were ovulating previously and then maybe now the person is not ovulating. But a lot of times you might not be able to know by yourself, except we do hormone profile and also some of those menstrual irregularities too, where you have periods of amenorrhea, when you are not menstruating, oligomenorrhea, and all might be suggestive. But the only way to make that diagnosis is to do an hormone profile and we'll check your progesterone level. There is a cutoff that will tell us if you're ovulating or not.
Awesome. Thank you very much. I would have loved to let you go now, Dr. Nima, because I know it's been a very long day for you. But I think this is really important and maybe personal to you as well. Because I know Dr. Nima created a video very recently about avoiding inserting objects into the vagina. So this person is asking, Dr. Nima, I think I lost it. What can one take for odor during intercourse due to PCOS? What can one take for odor during intercourse due to PCOS? So I think I'll give you a minute to address that and address the whole looking for something to take care of odor, especially in the vagina. Thank you.
Okay, thank you so much for that question. So, Sister Zainab, you are very right. I'm passionate about things like this. So the thing is, so the thing is that PCOS is not what we cause odor during intercourse. When an individual is obesity plus, okay, maybe because PCOS is also associated with hyperandrogenism, there is increased sweating and all of that. Yes, but obesity in itself, there is a lot of fat folds. So one has to take extra effort in being hygienic. So PCOS is not equal to having odor during intercourse. One must work on one's weight, make extra effort on hygiene. Hygiene, like wash that area with soft soap and water. There is no need to be putting anything inside. I've said it before and I'm saying it again. You don't have to insert anything in your vagina. Just keep that place dry. When you have your bath and you oil every part of your body, oil your vulva area, your vagina, oil it. Because a lot of people with PCOS are obese, they have a lot of skin folds, they have issues with managing all of those folds and all. You even see some people, apart from having acanthosis nigricans, they have tinea corporis. So they have tinea, they have fungal infection on the skin. So one has to take extra efforts to take care of all of those skin folds. But most importantly is shedding weight. It cannot be overemphasized. As in, it cannot be overemphasized. And it's not something that one will be playing a victim about. We've had people online who have shown their stories, success stories of weight loss and all of that without even doing surgeries, exercise and diet majorly. It requires a lot of discipline. So PCOS is not what we cause odor during intercourse. It is the fact that PCOS is associated with obesity and there is increased circulating androgen that might cause a lot of sweating, a lot of, all of the, how do I put it now? um yes, a lot of sweating and the old skin folds and all. So PCOS is not associated with odor during intercourse, but one should try to shed weight and ensure hygiene. So just keep the place clean. Don't wear one pants more than for as in wear one pant a day. If you can even wear two pants a day, fine if you want to. Keep that area dry. Keep it dry. Very, very important. Then take care of your vulva, that area, like you take care of your face. A lot of people oil every part of their body and they forget that place. And then you say it's smelling. Then you go to urinate, you use water to rinse, your vulva is wet, you wear a wet pant on top, and then what do you expect? Of course, there will be smell, there could be infections too. So let's just take extra effort in taking care of that area and it will make a difference. So I don't think PCOS is associated with having odor during intercourse. Thank you.
All right, thank you so much, Dr. Nima. It's been very awesome having you answer all of those questions. Thank you once again, and thank you to everyone who has contributed to this webinar. I have a question from Aziza Karim, but we're not going to discuss that here. Can you kindly send an email to whtinigeria@gmail.com? Your question is more personal and will take some level of explaining and more discussion to answer. So that would be all for the questions today, and that would be all for the webinar. Again, for those that have won our prizes today, please send us an email, or if you're comfortable sharing your account details with us right here, you can send it to WHTI and we would see it. At this point, we want to acknowledge Focus Games. Those were the ones who launched the PCOS game just to provide more awareness. You see, a lot of people are doing lots of things, and you can also be a part. You don't have to be a medical personnel to join us. You can volunteer with us. Our volunteers have been working ceaselessly and effortlessly to make this a reality. This is also to acknowledge and appreciate all of our volunteers as well. On that note, ladies and gentlemen, from wherever part of the world you're joining us, I know a couple of the majority are from Nigeria, and I know some people are joining from Canada, from some from the United States, from the United Kingdom. I hope you all have a good rest of your day. Remember to stay healthy. Remember, if you have any questions regarding your health as a woman, WHTI is here for you. On that note, ladies and gentlemen, we have come to the end of this webinar. Thank you so much for joining us.